David, you mentioned there are legislative and regulatory issues that are directly will affect kidney care. Do you want to sort of go through some of those really quickly?
Sure. I think first and foremost, there's going to be a real push, and there is already a push on Capitol Hill to adjust or neutralize for the time being some of the cuts and offsets, particularly around labor cost in the country right now. And they are having massive impact in nephrology, particularly in cases of dialysis facilities, where there's a tremendous crunch in terms of cost and also labor shortages. And a lot of the labor shortages are being met with travel nurses, which can be a very, very, very expensive way in which to approach your situation, a very expensive way to approach staffing. So there's a lot of conversation around that. There's conversation around the clinical labor cost cuts that would impact vascular access opportunities and could actually, in the end, push more people into positions where they have to go into hospitals for even more expensive vascular access care to the system than it would be otherwise, which is kind of very counterintuitive. There is also a conversation of looking at the issue of paying for both a limited amount of dialysis and hospice at the same time, something that every one of our listeners knows is just a very sad situation when they come together. And you and I both have talked about it before and have seen it happen, where you have to make a choice one way or the other for an individual who is probably ready for hospice care and they are trying to make a transition on dialysis. I think that one really has potential to get worked into some kind of an agreement, hopefully this year. That would be great.
So you sounds like you're optimistic about the final one. I guess the one before that about payment for vascular access or dialysis access. What's your guess as to how that will turn out?
Actually, I probably should restate that a little bit. I think that part of the reason why the other one, the one could be promising, is that it would be far less expensive, but also the fact that the dialysis facility one the labor costs there may really need some attention from Congress this year, or really does need attention from Congress this year, could make it possible that gets combined. But we don't know that yet. We've just been talking about it and looking at it. And some of the same players in Capitol Hill are involved in looking at all those issues. So they could somehow end up being put together. But this is a very, very early prediction. And, just don't, as always, don't hold me to it. But I think I would be encouraged about that conversation. I think everyone knows that there's going to have to be some work around the labor cost issue in healthcare.
Yeah, it's interesting because in the last month or so, I've been in a number of meetings and discussions, and the issue of healthcare workforce in general and the nephrology workforce in particular has come up. And you mentioned some of the challenges related to the workforce of nephrology nurses. There was a report that came out earlier this year that was an international sort of collaboration around sort of estimating what the nursing shortage is likely to look like over the next decade. And this group estimated that it'll be, that we may be short up to 13 million nurses globally. Currently, there's about 28 million nurses that work across the planet. So you sort of think about that in terms of, what that shortage could be. And specifically for the United States, there was an estimate by McKinsey & Company that it would be somewhere between 200,000 and 450,000 nurses by in the next couple of years. And so, that's moving quickly it's already a crisis. And I think it's going to be, even more of a crisis. I think will have implications across the healthcare system. If you shift gears and think about the physician workforce, at least in the United States, the Association of American Medical Colleges has estimated we'll be short somewhere between, 37,000 to 124,000 physicians by 2034. So, that outlook, both for nurses and for physicians, including nephrologists, is not optimistic. And I'm just sort of curious as to when you are either on Capitol Hill or interacting with the regulatory, HHS and others, sort of what you're hearing about these issues.
I think that these issues are just kind of, they're hard to get your mind wrapped around because it's very difficult to figure out what you could do, what levers you pull and change. The most common one often referred to is thoughts of loan forgiveness, particularly around nursing. That's been a very big issue about the idea of being able to create programs that would absorb those and therefore really incentivize people to go into a space that they might come out of debt free and be able to work, within a salary range that would, that could make things very attractive for some people. And that would be, that would certainly be something that I think we would look at very positively and try to figure out. So while we would certainly consider a proposal like that for nephrology nurses, once you start to ask for that, then every nursing group in the country is going to say the same thing. And maybe that would be the better approach. But it is certainly going to be very expensive. I find one of the things very disturbing that is dawning on people is that we are in a really focused period where we are trying to deal with the inequities and the access issues around healthcare and around access to doctors and access to everything else that is needed to keep people healthy. And if you look at those numbers it doesn't take much thinking to figure out that when those things begin to happen, they're going to really affect those individuals who already have access issues. They're going to be some of the people most squeezed by that. And so if you're in a rural area, lower income, and just in a lot of different categories where you generally are not getting access to care the way, that a lot of us believe everyone should have a right to in the United States, then you can begin to see that the writing on the wall, which says that situation gets worse.
Yeah, you're raising two separate issues that I'd like to try to parse and address separately. So let me do them in reverse order. So the first is this issue of healthcare justice, and if you have shortages of health professionals, including physicians and nurses, then populations that are already underserved are going to have even less access. And so, do you think the solution for that, from a policy perspective, is by focusing on the workforce, or do you think there are other levers within the healthcare system or within society? I mean, I'm just kind of curious as to your advice as to what a potential policy agenda would look like.
I think you're going to really address that, you're going to have to go across the board. And I think workforce issues would be very important and very useful, but you wouldn't stop there. And there's a lot of groups in the government and outside the government who are trying to figure out how to more equitably access care for a lot of people in the United States who seem to be really not able to do as well. So it's going to be a lot of different things. And as you know, we really have been focusing on this very heavily for many years at ASN, because we really do see the impact of inequities in kidney care and in kidney disease. So that's really a critical thing. It's just not going to get fixed with one thing alone. But yes, the workforce issues do need to be addressed. And I think Congress is going to have to do some even more dramatic things than it has already done in terms of trying to, so for example, of the Conrad 30, which, I'm not the best one to describe Conrad 30. Can you do it, Todd?
Yeah, so essentially the Conrad 30 waiver program, which is named for a former U.S. Senator from North Dakota, Kent Conrad, is a waiver program, and it allows international graduates who are on J-1 visas to essentially have a waiver to serve to work in areas that are underserved in terms of not having adequate number of physicians. And part of the challenge is it's very targeted to primary care physicians. So it kind of gets to the first point that you made about the workforce that I wanted to circle back to when we parse the two issues, which is as much as we'd like to look at these from the perspective of nephrology, I think the challenge is that if we have shortages of, even though we have shortages of nephrologists and nephrology nurses, that's within a broader context of shortages of physicians, particularly primary care physicians and nurses. And so it's difficult for ASN and for the kidney community to advocate specifically for support to increase the supply of nephrologists and nephrology nurses, because you've got all these other organizations either advocating for their specific specialty or trying to do this collectively. And I think that becomes the challenge if you think of this from a how you put together an advocacy effort. And just want to make sure I have that correct before we move on.
Yes, I think you have that in proper perspective.
So maybe just to move to a third issue, if 2022 is the year of the tiger and the Chinese zodiac, it's also the year of private equity and nephrology. And we just, seems like every month there's announcements of new partnerships and activities. And I'm just curious as to how that's being received in the policy arena.
Well, I think everyone is trying to figure out exactly where this goes. It's clear that the trends, are very, very, the stakes are very, very high. A couple of months ago in the Senate Banking Committee, the discussion of private equity in healthcare, the number that was used most commonly was $750 billion over the last 10 years had been invested in healthcare private equity. And I think most people would say that number is underreported. There's a lot of different ways in which you go about that. And so, that is changing dramatically, kind of certain things about premises about the way healthcare will be delivered, and also even things like healthcare debt and how it will be pursued, which has been a very big interest to Senator Elizabeth Warren, Democrat of Massachusetts, and she did talk about that at that banking hearing that I'm mentioning. But it's really kind of an amazing amount of money coming into the system. But I think you and I have talked about this some. The interesting thing is it hasn't been as prevalent in the kidney space as it has been in other spaces. And I think now we're beginning to see that change. And I think that has some groups, a little bit more concerned.
When you say some groups, what do you mean?
Well, I would imagine that if you're in the business of providing dialysis, that you might be concerned about seeing some of that movement into there. We're definitely seeing it in terms of various new groups coming in to try to bundle together patients who have kidney issues who have been put into Medicare Advantage or who've joined Medicare Advantage. How will that change, particularly since those groups will be handled on a contractual basis and not necessarily the same way the government oversees the patients that are in regular fee-for-service Medicare.
Yeah, I guess, it's interesting. You'd mentioned Medicare Advantage, and we haven't talked as much about that. I'm kind of curious as to, it seems like that's almost the transitional step. I don't know if you think that's right. I mean, I'm trying to think of how to ask this question.
Well, I think that the question is will Medicare Advantage be a catalyst or will it be an outcome? And I think that it may actually become a bit of a catalyst. And let's just say that Medicare Advantage has the chance to be a game changer along with the introduction of private equity into dealing more with, cohorts of kidney patients.
So, David, one last question. You mentioned that between Medicare Advantage and private equity, it'll be transformative for nephrology care, including dialysis care. What do you see as the role of the nephrologist in this brave new world?
Well, I should say, you said would be transformative, and you're quoting me, and I should say could be transformative, because I think there are certain factors there. But the role of the nephrologist is very interesting. There are some listeners out there who are concerned that they think that nephrology practices are going to come under a lot of pressure to be bought out by private equity groups and also even possibly by dialysis providers. I'm not saying that's the case, so please don't, have everyone kind of call up to say that, I'm trying to scare people. I'm not. I'm just saying that there's some interest in that. I think there's going to be some real change in terms of just what the role is of a nephrologist as we look at more tailored and more really kind of specific accountable care organizations, which is really where we're trying to go to order to contain cost. And I think it's going to be a very interesting point at which nephrologists we're going to really be talking a lot about, the value of the nephrologist in the healthcare system. And I know we've already been talking about that a great deal, that you've been working with a lot in different entities, different groups within the association, within the society.
Yeah, I think that's a good place to stop. And maybe, we'd already had a previous discussion about this ASN task force on the future of nephrology. That group is meeting weekly and is really starting to have just a fascinating conversation about sort of where nephrology could head as a specialty. And I look forward to updating that with you and also inviting others involved in that project to participate in future discussions. So maybe we should stop there. And again, David, I appreciate your taking the time and everything you do to help advance all of these issues.
Thank you, Todd.